for the neonatal patient population, for nursing practice consists of high-risk perinatal care, neonatal intensive care, and nursing informatics as well. And our passion for trauma-informed family integrated care for professional work. In August of 2022, Jessie experienced firsthand when her daughter was born at 27 weeks, 5 days after sentinel abruption, experiencing the environment that she wasn't familiar with from the other side. She says, describes as exhausting, traumatic, but most of all, hopeful. Jessie holds a Master of Science in Nursing Education and certifications in high-risk neonatal nursing, nursing professional development, and care of the extremely vulnerable infant. She's a graduate of the Trauma-Informed Professional Certificate Program and a Community Resilience Model teacher. She serves as co-chair for the Equity, Diversity, Inclusion, and Belonging Committee for the FCC Task Force, a national organization focused on improving family-centered care in neonatal intensive care units. She's also the neonatal outreach coordinator for the Atlanta Panhandle region, and we're really looking forward to hearing what you've prepared, Jessica.
Thank you, guys. I am going to share. We tested this before, but you can never trust. I want to make sure you guys can see the full size version. Does it look good to you?
You're good to go.
All right. So today we're going to talk about how can we support the provision of human milk using a trauma-informed foundation. So disclosure, like was mentioned, I am on the Executive Council for the Family Centered Care Task Force. And then just a general disclaimer, while evidence supports the information that I'm going to provide to you, I am not speaking on behalf of Emory University or any other affiliated organization. The opinions expressed here are my own. So what I hope to accomplish in the next 45 or so minutes that we have together is we're going to identify definitions for trauma and trauma-informed care, discuss the importance of using a trauma-informed foundation when supporting lactating parents, and list 2 ways the healthcare team can implement trauma-informed lactation support. I will go ahead and kind of address up front that I will be using kind of a mix of gendered and non-gendered description in an attempt to be kind of inclusive and normalize some different ways to talk about this very important process that we support in families. So let's start right off the bat with how do we define trauma? So SAMHSA, which is the Substance Abuse and Mental Health Services Administration, in 2014 kind of had a landmark publication where they really tried to set a very clear definition for trauma-informed care and trauma itself so that it could be used outside of more than just the psych type facilities. Of course, this, our psych colleagues have been dealing with this forever, but it's kind of come into all these other areas because we realize that the traumatized individual shows up and needs healthcare and support in other ways. So the way they define it is the individual trauma results from an event, a series of events, or a set of circumstances that is experienced by an individual as physically or emotionally harmful or life-threatening, and that has lasting adverse effects on the individual's functioning and mental, physical, social, emotional, or spiritual well-being. So those are what's known as the 3 E's of trauma. So it's the event, the experience, and the effect. So essentially what it boils down to is it's whatever the individual experiencing it says it is. We believe people when they share their past experiences. And that's really hard to do because we tend to center our own experiences and we're like, well, I was a single mom and it was fine. I didn't have all these issues. She should be fine. Or I was a teen mom and I was able to provide breast milk. Why can't this person? So it's realizing that your past experience and your set of privilege or access or whatever word you want to use is not the same as anybody else's. So while you might have shared the same event in a kind of title sense, the combination of all of the past experiences and present, availability makes it individual for every person. So we have to remind ourselves when we're practicing from a trauma-informed place that it's not about us, that it's about the person that we're trying to help. So just a brief nervous system review. I'm not going to get too far in the weeds here because we're all in healthcare. But the amygdala is what's responsible for constantly scanning the environment for threats. It's important to have an amygdala that functions, right? Because it's what keeps us from walking out in front of a bus that we might not have seen, but somehow our senses were kind of able to sense that something was going on. This is what tells us, hey, when there's a dog barking that you can't see clearly is on a chain, maybe you should go on the other direction. It's what keeps us safe. And we want to partner with our amygdala if we can and be like, cool, you kept me safe. I didn't get a dog bite. That's awesome. But sometimes in people that have experienced trauma, that amygdala is hypersensitive and they will perceive threats that might not be apparent to someone else because it's actually a recall of past experiences. So it's just as real, like the sensation is just as real to that person, but it can be challenging for other people to relate to it because it's not real to us, it's real to them. So way back in the day, we used to be like, oh, it's in your head. But that's not helpful, right? It's like when you're having an argument with somebody and they're just like, I really wish you would just calm down. It never helps. If anything, it always makes things worse. So you want to find the way of saying, like, validating and find experiences that can be kind of approving of what this person is experiencing while also centering that they're safe right now. So it activates either a sympathetic or a parasympathetic nervous system to achieve safety. So then we end up with our safety seeking responses, which we'll cover next. So these adaptations that come from our safety seeking responses are great and they help keep us alive because that's our brain's, this part of the brain at least, that's its whole goal is to stay alive. So it's go into, different responses to stay alive. And that's really helpful, except for sometimes in that heightened sensitivity, they're not able to downregulate. And so now you function at a higher state. So where you might have everything be the same, all descriptions be the same as someone else. But if you experience trauma and someone else didn't, then you're already going to have an increased response to stimuli that is familiar to that traumatic event than you will someone who did not experience it. So adaptations are great unless you're not able to turn them off. So the safety seeking responses, and this is more commonly known as trauma responses. I like to refer to them as safety seeking responses because that's ultimately what your body is doing or what your brain is doing. And it also helps to destigmatize trauma response because trauma, like a lot of the words, I think is kind of getting taken over, right? With like the zeitgeist in general. So you'll hear things like, oh man, that test traumatized me, or oh, I picked up an overtime shift. It's so traumatic to have to come in here. And I mean, I guess in the SAMHSA definition, perhaps it was traumatic, right, to you and not me, but it also gets overused to the point that it has a stigma associated with it. So if we think of it from the perspective of safety seeking, it kind of neutralizes some of that. So most of us are familiar with fight and flight. That is typically what is discussed, right? You have the intent to defeat the threat in the fight response. You have the intent to run away from the threat in the flight response, which is kind of like your base level. But our brains have nuance. And so there's more responses. And these are the four like most prominent. There's actually up to 7. They're just a little bit less established in the literature, those last 3. Freeze is your intent to hide from the threat. If I'm really still, maybe the bear won't see me and he'll go somewhere else, right? It's trying to like disappear into the wall. I usually explain this to my new grads as this is when you see your first code and you're trying to disappear into the wall and not be asked to do anything, right? The fawn response is the intent to please the threat in hopes of neutralizing or distracting it. This is important to talk about when we're talking about perinatal trauma and birth-related trauma because it is disproportionately experienced in people that are socialized as female. There's a lot of society things and cultural things across multiple cultures that go into this. But basically, it's this idea that you have to be the good girl or good person, be nice, be the peacekeeper. And so you'll feel the need to be abundantly gracious or thankful or gratitude and all those things to try to neutralize the threat. It's not that being gracious or grateful is a bad thing, but it's when you're doing it to the point that you're denying your own pain or your own existence, then it can become harmful. We see this a lot in all of the like women's services. And sometimes we tend to prefer the patient in a fawn response, right? They're the one that's like, oh my gosh, you're the best nurse ever. This is amazing. I'm going to have a great day. We're going to latch and it's going to be great. Versus the fight response might be maybe less desirable, right? In most settings. But sometimes you have to kind of find the line of, are they really grateful? Because that's also true. Or are they just an abundantly positive person? Because that's also possible. Or is there a way for me to also validate some other things that I might be seeing or give them permission to feel something more than just positivity? Because positivity, like all things, can turn into like a toxic state where now you're denying anything that's maybe negative or even neutral around you because you feel this need to only have good vibes only. Those are the only kind that are allowed. But life is full of ups and downs and a full spectrum of emotions. So you're never going to always feel good. as much as you might want to. So now let's talk a little bit and start connecting some of these principles into lactation support. So Wheeler in 2025, which is a new one, came out in January. I was looking for some studies for this and was like, oh, this is interesting. So they surveyed parents who identified as having experienced a traumatic birth, because remember, trauma is what somebody says it is, right? So they've identified that their birth was traumatic in some way. Another important note to call out is most of their data collection was during the COVID-19, like the height of COVID-19 pandemic, which as a person who had 2 children during that pandemic, I can vouch to the traumatic nature of those experiences. Although some of their data was collected for about a year or so before. So they felt like they needed to call it out because that was a shared traumatic experience, something akin to like war or 9/11, big events that a whole community experiences, but every individual will experience it differently. What they found was those with an uncomplicated lactation journey, where it seemed easy, quote unquote, found the whole process very healing. And it helped them bond with their baby. And they felt that it decreased the impacts of their traumatic birth because they were able to receive such positive feedback from a mental health perspective while nourishing their baby with their body. But the opposite was true for people who had a challenging journey. So those with a complicated lactation journey, so exhaustion, a lot of pain, low milk supply, they found that it compounded the trauma experience and negatively impacted their recovery and bonding. And post-traumatic stress disorder, depression, psychological distress in general are also associated with low breastfeeding rates. Now, often when I talk about trauma, it starts out feeling very like, well, this is sad. She's going to have a whole sad hour-long presentation and I'm going to feel terrible by the end of it. I promise you that's not the case. I think it's getting comfortable being uncomfortable, because that's kind of my like motto in life. Because when you get uncomfortable, it also helps you realize where the opportunities are. So while my personal NICU stay, like we shared earlier, was traumatic and was exhausting, because ask any NICU parent and they'll tell you how tiring it is. But it was also hopeful for me because it taught me so much about all the opportunities we have to adjust things for both the babies, the families, and the clinicians. So that's my general approach to trauma-informed care is, yeah, I'm going to talk about some sad things, but I'm going to talk about them so that we can figure out how to support people who are experiencing them rather than asking them to just not experience it. Because that's kind of historically what we've done is, oh, you don't have a problem. It's okay. It's hard sometimes. And that can be true. But if they're having a genuine problem, especially from a trauma response place, we're better to connect them to safety before we ask them to do something else. So I want to go on and get this kind of out of the way as well. Some factors that could be associated with someone's decision to pursue lactation or not. And I want to do the negative ones first, because that's typically what people think of. Commonly when I'm teaching this hot topic, I'll hear like, oh, so you mean like a sex trafficking victim, which absolutely, yes. Like, I don't think anybody in the world would argue that that is not traumatic. But I just want to call out that it's a little more nuanced than that. We used to, back in the day, refer to big T traumas and little t traumas. We, kind of stopped doing that because that's inherently a judgment call on someone's experience, and the whole vibe is to not do that. But of course, you have things like sexual assault, intimate partner violence, abuse of any kind. Kind of immediately come to mind as, well, someone might have a hard time with lactation because of that. But then there's also, maybe they had a challenging lactation experience before. They struggled with low milk supply. They were never able to really get a baby latched and had to pump. And while they were grateful for that, it didn't quite meet expectation. Their overall mental health status, maybe they have an underlying diagnosis of anxiety or depression or something else, their birth trauma experience, infant requiring treatment in the NICU, that alone is a traumatic factor, and then family history and generational trauma. In some communities, breastfeeding rates are low, and it's more than just they don't know enough. We have to teach them. Sometimes it's a public health initiative and a cultural initiative. It's really hard for some breastfeeding parents to say, I want to breastfeed, let's do this. And then they get home and the first thing grandma or auntie or somebody says is, that baby's hungry, you got to give him a bottle. And then they're like, okay, well, I'm exhausted physically. I'm exhausted emotionally. This doesn't seem to be knocking it out of the park. Maybe I should just do it, right? And so it's really hard to combat those like ingrained systems. Doesn't mean we shouldn't try, right? But I think we have to be realistic in the sense that some of these are larger issues than a pamphlet in an OB clinic is going to solve, right? So some positive decisions, things that might make somebody really, try their absolute best for lactation and hopefully succeed in whatever their goal is their overall values. They find that nourishing their baby with their body or providing human milk is something they value very highly. Maybe it's even a part of how they view motherhood. Maybe they had really good success with a prior lactation experience and they're like, I've done it before, I can do this again, even if it's challenging. They find meaningfulness in it, health benefits for lactating person and or infant, of which everyone on this call knows there is a list of. It promotes bonding, connection. They have a support system that is able to help. That kind of bleeds into both sides of it, because if the lack of that support system can make it really hard to be the person that's on an island by themselves, or the perception of that, trying to promote this type of nutrition for their baby. Finances, we used to say it's free. And then we learned from Yale that it's like $13,000 a year or something. Like, it's not free, right? Now, of course, compared to the cost of formula, I guess, sure, it's less. But we also want to honor the effort that goes into the person producing milk and the sacrifices that they might be making, whether it's sleeping or work accommodations, all that kind of stuff. Because I feel like honoring that effort just doubly enforces the labor of love that lactation is, rather than looking at it as something that's negative. And then, of course, the family's lactation history. If they're kind of first generation person doing it, that might be more challenging versus they come from a family history where everybody breastfed. It's associated with, their family story almost. Then they don't feel like less of an outlier and they feel more like they're falling in line with what their family does. So now let's talk a little bit about trauma-informed care. So we said earlier that SAMHSA defined both concepts. So we kind of established trauma and things that might influence somebody's experience with lactation related to trauma. So now let's talk about trauma-informed care and then spend some time talking about how to practice it. So trauma-informed care is a program, organization, or system that is trauma-informed, realizes the widespread impact of trauma, and understands potential paths for recovery. They recognize the signs and symptoms of trauma in clients, families, staff, and others involved with the system. They respond by fully integrating knowledge about trauma into policies, procedures, and practices, and they seek to actively resist re-traumatization. So just like we had the 3 E's of trauma, these are what is known as the 4 R's of trauma-informed care. So you have to realize the impact, recognize the sign, respond by, attending these webinars and educating yourself in your own way, and then resist re-traumatization. That last one can be hard for us because we don't have control over it. Now, we want to operate from a place of neutrality as much as we can, but in the end, we can't take away someone's trauma response. All we can do is hold space and provide validation. So the act of lactation for some people might be re-traumatizing. So then we need to look at what accommodations can we make? How can we make the next feasible option? So is it using a cover at certain times? Is it doing it alone or with a specific support person there? Is it a certain gender lactation consultant? Is it maybe even a specific type of lactation consultant who has further training or has some kind of cultural congruency of some kind, some way to neutralize the threat that this person is perceiving? Because, we know that we are not actively trying to harm people, but that doesn't mean that harm isn't happening. So it's all about how can I pivot and how can I have the system pivot to still support this person's goals? So we can't talk about trauma without talking about resilience. So resilience is this concept of kind of trying to survive or thrive in the face of adversity. Survival is our first goal, but thriving is like where we really want to be, right? You never want to look at somebody and be like, I just hope you survive the day. Like you tell your kids, you send them off, or your spouse or loved one, you want them to have a good day, right? So we're trying to get to survival is step 1, and then how do we inch forward to something that is full success and thriving? So again, it's that pivoting to the most feasible option. So are you having challenges with the latch after working on it? Is it feasible and desirable for that person to bottle feed express breast milk? And that feasible and desirable is what's important, is what can actually happen, and then does that person want it? Because at the end of the day, no one is here to argue that it's not important to breastfeed babies or that breast milk doesn't provide the perfect amount of nutrition, right? We all know the science. It's been settled for a long time. But at the end of the day, it's not our body producing the milk. So we have to partner with this person to do whatever is feasible and desirable for their lactation journey. So maybe they're fighting with a low milk supply, delayed lactogenesis, maybe they have some neuroendocrine things, they have other challenges that are keeping them from able to achieve full volume. Is it feasible and desirable to combo feed or maybe pump and provide the amount the parent can produce? So if they can make 240 mLs in a day, then we're going to give those 240 mLs, to that baby, and we're going to be grateful for every single one of them. And we're going to do it as long as that parent is capable. If they're capable for 3 months, great. If they're capable for 6 months and it doesn't affect them in any negative way, even better. But we're giving the choice back to that person because ultimately we're not the one with the baby attached to our body or the breast pump attached to our body. So it's finding a way for them to even see their own challenges from a place of neutrality and find the agency and choice in it rather than thinking, well, I just must give up or this is never going to work. Well, maybe we just need to redefine success and then be able to maybe inch the goalpost once we kind of get better and get established. But we don't have to throw the baby out with the bathwater. And we also don't have to make somebody feel pressured to do something when they really just need somebody to say, hey, this is hard for you, and this is what I can do to offer like a help or an alternative. So some core principles that you want to try to incorporate in your interaction. So education, support, consults, policy, like really try to put this in like your cap on. We tend to write those kinds of guidelines and documents from a healthcare centered perspective, but we have to challenge ourselves to switch and be family and, person centered and find where can we provide autonomy, choice, agency, and consent. Because ultimately, that's what every person is owed, regardless of any kind of way you want to define people, right? Race, age, financial status, insurance status, what language they speak. None of those other things matter if they don't have access to autonomy, choice, agency, and consent. So autonomy is the ability for them to make their own decisions. Now it's an informed decision, and that's where we have responsibility to make sure that we're informing it in a neutral or positive way. And then choice, ultimately, they have a choice. And then we want to support them in what that choice is. Agency is empowering them to understand that they do have autonomy, that they have the ability to make a decision, because sometimes the hierarchy in medicine puts patients at the bottom, even though we do a lot of speaking that they're in the middle or the center and everything we do is for them, which is true, but we don't always have that be accurate in the systems that we function in. And so it's giving them to say like, yes, you get to make the decision. I always think about this, like when you're having a parent change a diaper for the first time and they're like, really, I can do that? And you're like, yeah, sure, baby, So it's facilitating the support that they need to act with agency. And then consent. Consent is important, gets its own slide. Absolutely have to have verbal consent prior to any physical contact. And for some people, you want to kind of reaffirm consent and decision to continue throughout encounters because their goals might have changed, right? And provide whatever validation is needed. Sometimes they might even be a little bit in that fawn response where they're just saying whatever needs to get said so that you feel great because they don't want to make your day bad by being a disappointment to you because they're deciding to change their goals. When really, my 12 hours or my life is my life. Like I'm going to come and go out of all these different experiences. I want to support you with whatever it is your goal is, but I just need you to feel safe enough to tell me what it is. And so this serves a double purpose. You're kind of eliciting consent, but you're checking in on where the last place that you thought the goals were, because maybe they changed 5 minutes after you saw them last, and now you need to adjust to pivot. So it kind of works for a dual purpose. So this might sound like, how are things going? I know our last session was very emotional. I want to support you and your baby. Let's talk about how to best do that. So an open-ended question and then reaffirming and like kind of validating that my job here is to support you. You just let me know what you need, right? Or that last session went so well. It seems like you're feeling confident about the different positions we've been working on. How do you feel about things? So again, you're finding a positive reinforcement and validation of something that is honest, right? Like maybe this person really tried a football hold for the first time and they were terrified, and then all of a sudden they're like, this is amazing. And you can call that out. But you're also eliciting, how do they feel? Are they feeling more confident? Because once you kind of can tap into their sense of agency, our job gets way easier because then they're like, oh, I can do this, right? We commonly will joke, I'm not going home with you, kind of thing, but we need to set them up for success. And we do this by promoting their own resiliency and their own agency at every step that we get. rather than making it feel like it's dependent on me being here. As a NICU nurse, we do this a lot with bottle feeding as well. Well, I can feed him. Well, it's not about us, right? Nobody's testing you for competence on feeding a baby. We need to know that the family feels comfortable feeding the baby, and even further, feels comfortable teaching someone else how to feed the baby, because when they go home, they are the baby's advocate. So we want to individualize support. We want to identify those goals and design support to achieve them. Be flexible as goals may change, like we talked about before. Be supportive and positive while leaving space for the full range of emotions. Something else I speak about frequently is toxic positivity. We do a lot of that in healthcare, and especially in women's. And it's not that you can't be positive, because you absolutely can, but you have to realize that the world exists in a full spectrum. So if you walk in a room and someone is having an emotional reaction, you could say something like, oh, those hormones, man, they make you feel crazy. Okay, let's get to work. Or you could be like, oh, okay, do you need a second? I did want to work on, with you with the baby. Is that something you still want to do? Because you're validating that I recognize that there's something going on. I'm offering a supportive place if you need somebody to hold space for what you're experiencing. But I'm also telling you, if you want to pivot and work on this other cool thing too, we can do that. Rather than just telling them, just be grateful that you can even do this. There's that, I just saw a mom this morning, and she had a mastectomy and can't, or has some other issues, and she can't even do this. And you're like, okay, but that's not me. Like, I'm in my room dealing with my issues, right? So try to get away from like comparison and toxic positivity, and more about validation and a realistic assessment, right? And then provide education and support free from judgment, which can also be hard, because just if you have a brain, you have biases, which kind of are rooted in judgments. And so if you're not mindful of it and cognizant of it, things will slip through. So you can have biases for anything, right? At a conference once, I heard somebody use the phrase, if you have a brain, you have a bias. And I tend to quote that a lot because it's so accurate. And biases work in both ways, positive and negative. You could have somebody and been like, oh, she reminds me so much of my youngest daughter. And, she struggled so much, but when we finally got the baby latched and got working, things went so well. So you might put in more effort for that person because your positive bias towards the memory of what was going on with your own daughter. Or in a negative sense, you might say, I believe in education for all families, but you disproportionately spend less time with families of color or families who speak a language other than English as their primary language. So while, yes, you're providing support, it's not the same as someone else. And some of these biases are implicit. We're not cognitively aware of them. So you have to kind of do some work on yourself, right, to kind of sort out what that looks like. And once you know them, then they're no longer implicit. Now they're kind of explicit because they're known. And then you can make a plan to work on them, right? And figure out, how can I counter whatever I might have picked up somewhere else. And a lot of this comes from community in general, how you were trained, what your preceptor did. Like, there's a lot of reasons. And so rather than looking at it as something that is wrong about you, just see it as something that just is a fact that you can then have agency on and change, because everybody has agency, no matter what situation you're looking at. Also addressing kind of inclusive language. So it really matters, because if you have somebody who identifies with other terms, they might not look to you for support, even though you might be the best person for them. You might be the most knowledgeable, you might be the most trauma informed, but if we're not adjusting to the need of the client, which doesn't mean you have to throw everything out, but you're kind of just assessing, like, okay, you prefer they, them, sounds great. I will do my best to accommodate, right? Or using things, especially from a research perspective, of doing things that are less gendered, or at least has an opportunity for a different one. So lactating parent versus using exclusively mom, human milk versus breast milk, or chest feeding versus breastfeeding, and then expanding breastfeeding also to apply to parents who exclusively pump. Sometimes you'll have somebody who is just like a stickler, and they're like, no, breastfeeding is for when there is a direct latch onto the nipple, which, yes, is breastfeeding, but breastfeeding can also be someone who is providing express breast milk. So just finding a way to be inclusive of whatever that person's experience is, so that they don't automatically feel othered by something that they may or may not be struggling with, and they're reaching out to support, because we want to be a safe space for all people. And then advocacy. We want to challenge ourselves to be the bridge between the parent and the healthcare team. It is really easy for us on the healthcare side to focus on the benefits and forget the person. Even in my own lactation journey in the NICU, I went in knowing that I have PCOS. I was never going to make more than 240 mLs in a day. I never did with any of my other pregnancies. I was willing and able and committed to giving her 240 mLs a day for as long as I could with my mental health. But it didn't stop people from saying the wildest of things to me. I remember I talked to a lactation consultant. She was like, "Do you like oatmeal?" And I was like, oatmeal is not going to change my insulin resistance and PCOS. Like, I appreciate it, but that's not really going to work here. And it felt like at times I was the only person that was okay with the fact that I was going to provide a limited amount of milk for my baby. I was going to do everything I could in my power to do it for as long as I could, but I seemed to be the only one that was okay with that. So it helps us if we can just adjust goals and realize that we're pivoting to the most feasible thing. You want to do all the things we know, promote sleep, nutrition, hydration, self-care. Most people find those things challenging to do with a newborn who's screaming to eat every 2.5 hours. So you also want to provide like realistic ways to do that, assess support, figure out what else they can do. And you might have a client who lives in a nutrition desert, doesn't have access to transportation, like they're not able to get to those lactation consultant appointments like we offer them, but if they're not able to access them, then it's not as easy and they're not benefiting in the same way as other people. And really try to make that perspective shift from, being entirely responsible for the person, right? Thinking like, make sure you're taking care of yourself. That's just kind of like a Hallmark card kind of way of like, you do it, right? You take care of yourself because no one else is going to. Versus how are you able to take care of yourself, or who can help take care of you? Because this also gives them a chance to reflect on their support system, which can have a positive effect on their nervous system, or can help them brainstorm, who could I call? Like, if I'm not able to get to the grocery store, well, my neighbor did offer to help, so maybe I'll reach out to them. Or if I have other kids and I really want to focus on, this session that someone's able to come to my house for, maybe grandma can come and watch the other kids so that I can do this. So it's helping them think about what access do they have to use the agency that we know that they have inherently. And then also advocate for systematic changes, things like health equity, paid parental leave, breastfeeding accommodations in the workplace. It's really hard to say, okay, go forth, breastfeed. It's going to be hard, but you can do it. And then they look at all the things and be like, oh my gosh, how am I supposed to do this? Or even compare to other outcomes in other countries that have access to some of these things, and then get upset about our numbers when you're like, right, but you have to look at the context of existence of the lactating parent to make the best decision. And the first thing that we do in advocating is learning about it and calling it out, naming it, and then we can focus on an advocacy role. Okay, what can I do? And maybe it's small advocacy. It's just the patients that I see and the facility that I work in, I'm going to try to chip away at these things. Or maybe you feel compelled to advocate on a bigger scale, whether it's a national organization or you want to put forth legislation and talk to your Congress people, right? There's all kinds of things you can do. So find something and plug in a way that feels safe for you. So in summary, and let's leave a little bit of time for some questions, we want to talk about trauma as being whatever someone says it is. When I'm teaching this to new grads, I usually talk about this in the context of pain. We don't argue with someone when they say their pain is a 10. We just go, okay, what do you think would help make it better? The other thing I like to bring up when we talk about trauma is you don't have to know the details of the traumatic event to do anything, right? So sometimes people will then push and they'll say, well, can you tell me about your experience with XYZ abuse? Or can you tell me about this? And we might mean it in a neutral way or even in an inquisitive way, or maybe even as something as like, that's our job, right? Because especially as nurses, we assess, that's what we do, right? You can't say I'm just in pain. We ask, what's the scale on 0 to 10? What does it feel like? When did it start? What makes it worse? What makes it better? Like we have all these follow-up questions. And sometimes we just have to acknowledge that things are, and we don't need to know anything further. If someone says that they're struggling, then we just go, okay, how can I help you? Or this is what I can offer to help you. We don't necessarily need to dig into the what. And then our past experiences provide context into current behaviors, and that's true for every living person with a nervous system. So that's true for you, it's true for the patient, it's true for the baby, right? So we want to be cue-based in all initiatives, which is like tying into cue-based feeding, right? Because we can make a baby eat, we can make them do a lot, but we know that our best practice is to provide positive neural pathways around eating. And so supporting the baby when they're interested and stopping and providing an alternative when they're not. The same goes for breastfeeding, right? And lactation support. Supporting in every way we can, providing options so that they can choose, okay, what am I going to do? What am I going to do next? And lactation is complex, just like we are. Sometimes we oversimplify really complex things because it makes our brains feel like we can manage it. But we really need to individualize because it truly, truly, truly is not one size fits all. What works for one patient in one room is not going to work for the next patient. Even pregnancy to pregnancy, things can be different. So even in the context of someone's own individual experience, they can have a dramatically different experience with each encounter. When in doubt, shoot for validation and assess their desires. Something that's supportive. I see that you might be struggling a little bit. I'm here to support you with that. Let's talk about what our next goal is. So it's not trying to talk them out of it. It's not trying to look the other way or crack a joke. In healthcare, we love some dark humor, myself included, but sometimes you have to read the room and figure out when is it appropriate for me to try to break the ice here and when do I just need to go, okay, the vibes are kind of heavy. This seems heavy and it's important. So what can I do to still achieve whatever success looks like for you now? Because it gives them permission to think about what success looks like now. Because for a lot of parents, it's going to be like, no, we're going to do this. And I want to use every tool available to me. And we can do that. But for some parents, it might just be like, you know what? This is what I'm capable of. And I just want support in doing it. Awesome. I can do that, right? Because at the end of the day, some breast milk is better than zero breast milk. So what a lot of the research around this topic talks about is we need to recognize when there is a history of trauma, and rather than deciding that that person can't breastfeed, it's understanding that they're at high risk for choosing not to. So what we need to focus on is functioning from a trauma-informed perspective, specifically for those patients, although I would argue everybody benefits from a trauma-informed approach. So if you just make it a part of your practice, you don't have to think about it. Because it's not like you're going to turn to them and being like, and now I'm at the trauma-informed, part of my assessment. Like you're just doing it. It just becomes how you are and what you do. And the spillover benefit is it also becomes how you show up in the world. It's how you go to the grocery store. It's how you go talk to your coworkers. It's how everything. Because if you live from a place where everybody has the capacity to have experienced trauma, it helps you tap into inherent empathy a lot quicker than if you live in a place where you feel like people are only entitled or they're exaggerating or something from a negative place. We just have to let people be who they are and have their experiences rather than try to change them. These are the references I chose. And that's it. I tried to keep it brief so we could talk a little bit about it if you guys were interested in it.